All right, welcome to today's meeting. The title of today's presentation is Composite, so the remarkable one-visit solution. And I really appreciate you all for attending the presentation. As we move into the presentation, I'd like to just disclose that neither I nor members of my immediate family have a financial relationship with the commercial entities that are relevant to this presentation. But the presentation is being brought to you by Clinician's Choice. So a lot of the products that we discuss will be Clinician's Choice products, which are very high quality products. But the ideas that we discuss are going to be universally applicable. So my name is Dr. Michael Miyazaki, and I am a practicing dentist. I've been in practice now for 30 years. I practice out in California, so I know a lot of our listeners are from all over the globe, but I'm in California in the United States. And I've been involved with education now for 27 years. And one of the groups that I'm currently involved with is called the Pacific Aesthetic Continuum. And I just bring this up because within this group, we do live patient treatment programs. So out of the 30 years of practice, 27 of that in education, probably about 20 years of that, I've been involved with live patient treatment programs, which means a lot of what I have taught, I've had to go into the clinic and actually work side by side with other clinicians as they worked on their patients. And this is not a dental school. This would be postgraduate, so with licensed dentists. And we'd actually go in and work with the patients side by side. And what I've learned is by observing is that no matter where you are in the globe, we have all the same issues. We have teeth that are pretty much universally the same. And I think collegially, we can share our experiences, and it makes all our clinical lives much easier. So what we're going to focus on in the hour that we have today, this is also one of the things that we do with this group is we practice comprehensive dentistry that we restore aesthetically. So a lot of we teach our dentists, our doctors to comprehensively diagnose the patients. And then the restorations that we place, whether they be dentures, implants, composites, inlays, onlays, or crowns, bridges, are all aesthetic restorations. And so today, we're going to concentrate in this hour that we have today basically on direct composite restorations, the layered direct placement method. And then towards the end of the hour, we're going to talk about aesthetic restorations with, again, composite. Minimally invasive, we'll talk about, I hope, some things that are very applicable to your clinical practice tomorrow or today, depending on what time it is where you reside. We know that there's a lot of different restorative solutions. There's amalgam, indirect restorations, and composite. Amalgam, we know, has value because it's a single visit type of restoration. It's very forgiving. Typically, many of these are not bonded in, they're just placed, but they're not very aesthetic. And oftentimes, if not the prep, the material itself over time can weaken the tooth structure and we can see a fracture. There's a debate among the different countries about the safety of amalgam because of the different materials that it contains. But I saw a patient this afternoon, and again, she had an amalgam and it caused a tooth to fracture, and now we're in a situation where she needs a root canal. So we know that amalgams can look good on the outside for decades, but underneath them, you can get decay that just kind of brews down there. Then we have indirect restorations. Indirect restorations are great if we need to strengthen a tooth, but many times it's going to be a multiple visit type of endeavor unless you have a CAD-CAM like a CEREC or an E4D within your practice. It's going to be more expensive typically for both the practice and for the patient, and it's going to be technique sensitive. So today what we're going to focus on is the composite restoration because it's a single visit, kind of like an amalgam. It could be much more aesthetic than an amalgam. And what I find is when we bond these restorations to the tooth, it actually strengthens the tooth structure. And I rarely see cusp fractures once we have a composite properly bonded to the tooth structure underneath. One of the challenges of the composite, with an amalgam, I said it had a more forgiving technique, but with the composite, it's technique sensitive. So the first part today, what I'm going to really focus on is on the technique. Because I feel if you get the technique, then you will have a lot of success in your practice placing these restorations. Today, the clinicians are, I guess, faced with all these different decisions. What do I need to make that tooth functional again? How can I conserve the tooth structure? Because we know that the tooth is basically living tissue. There's a pulp and blood vessels within the pulp chamber, and we don't want to cause any needless damage to that. And then when we're done with restoring that tooth to function and strength, the patient's usually concerned about the aesthetics. So when we're talking about different materials and different clinical restorative decision making, these are some of the things that I take into consideration. So let's talk about adhesive dentistry. Bonding. Adhesive dentistry is that branch of dentistry which deals with adhesion or bonding of adhesive materials or cements to natural substance like of the teeth, enamel, and dentin. And I look at a case like this. This was a case where we had a 14, 15-year-old boy got elbowed playing basketball, popped off the top part of his crown, exposed the pulp. So we discussed all the different options: extraction, implant, stay plate, partial denture, all those types of options. But because of his age, an implant wasn't highly recommended. So what we ended up doing is just adhesively bonding the piece back onto the root area of that tooth. And the photo that you see on the right-hand side is over 6 months later. It's holding up fine. So adhesive dentistry done properly is a great alternative for many different situations. And you can kind of tell that far right-hand photo is not the initial photo, because the photo on the left-hand side, that was the day that we actually did the procedure, and his tissues, his gums actually looked in better shape on the right-hand side. I don't think he's been brushing very well. The conservative aspect of composite, to be able to go in there, remove decay or old restorations and restore a tooth to something that looks aesthetic, where the patient's happy again when they smile and they're confident, is something that we can do very well with composite. Single tooth restorations are very difficult. A lot of times to use a lab fabricated restoration, because we try to match the different subtleties and color with an indirect lab fabricated restoration. Is that lab communication is very critical. With the direct type of restoration, we have the ability to, right in front of us, alter colors, alter contours to get that final shape. And aesthetics is just so important, because on the top you see old crowns and on the bottom you see porcelain restorations, and it's just fun to be able to see what we can do for our patients using more aesthetic materials. On composites, though, to be able to take out these old amalgams and restore the teeth, I think it's actually better, makes the tooth stronger, and so much more aesthetic that our patients just love to see those restorations versus the dark circles that they had. So let's start off with bonding. How do we do bonding well? Well, I think visibility is important. Retraction. Some of us use rubber dams. In my opinion, rubber dams have never been the easiest thing to use, but they served their function well. They kept the field isolated. But now there's other options like Isolite and Dry Shield. I'm just showing a Dry Shield here, where we hook that up to a high volume evacuator. And that little silicone piece has a little mouth prop on it, so the patient can open, we slide that in, they can rest their jaw. Part of this holds the cheek out of the way, part of it holds the tongue out of the way, and it provides suction. So being able to isolate the area in which we're working and do it well and in a comfortable way is much nicer for our patients. And I will tell you, it makes my job so much easier. So here you can see this is a Dry Shield in place. The little holes in that are what sucks any moisture out, and even the humidity in the patient's oral cavity is kept lower because of that ongoing suction. So you can see everything is very well isolated, and it really makes the job a lot easier for me. A lot of times my assistant gets that in place and she can take off and go do something else. Magnification is really important, because if you can't see it, you can't treat it, and sometimes you can't be sure you got all the decay out. So really, magnification with the light I find is important. I have an oroscopic eye zoom that has multiple magnifications with the Spark, which is a little wireless light. I have a Design for Visions loops with some laser protection. I have perioptics, and these all go from about 2.5 to 5 powers. And it really helps me, not only helps me with the preparation to be sure I get all the decay out, but it helps me with the finishing also. Step two, just to make sure we get all the decay out. So I will use things like Caries Finder or Sable Seek to make sure I get all the decay out. So I do my prep. I'll put some of the Caries Finder in there, rinse it out. And if I see a lot of green or red, depending on which color I used, left behind, I'll go in there and be sure that I remove that. Green fluoresces with the Dynadent, so if you're a Dynadent user, it can give you false positives, so in that case you might use a red. But otherwise, I always like using green just because red, you can't tell if it's the pulp, you can't tell if it's bleeding, and the green is, I think, easier to discern. Tissue management. When we place a direct composite restoration, we have areas of deep decay. It might be subgingival. And when we start prepping that area, we don't know what to do when we get bleeding. So you might pack a cord. If I do pack a cord, which is fairly rare, we do it very gently, but we hold the tissue down. I always like to make sure that none of the fibers of the cord get incorporated into a composite once you place it. And that's one of the reasons why I don't like using a cord. If I use a hemostatic agent, I like Astringent X. It's an Ultradent product. It's very strong. And the reason why I jump from nothing to Astringent X is just my interim is using a laser. So what I'll do is I'll use a laser. I'll trough the area to get the tissue out of the way. And a soft tissue diode laser at the same time will give me the hemostasis I'm looking for. And if I don't get the hemostasis using a soft tissue diode laser, then I'll go in there with the Astringent X. Etching. Etching is critical. We know that there's different parts of a tooth. We have the enamel with the enamel prisms. We have the dentin with the tubules that ultimately go down into the pulp chamber of the nerve. So when we apply the etchant, we want to do so in a very controlled way because we know we have the odontoblast and those dental tubules. And if I do anything that alters the hydraulic pressure in those tubules, and those odontoblasts will let my patients know that they're sensitive. So when you come down to an etchant, one of the clinician's choices etchants is this Max Etch. Now, Max Etch is a 35% phosphoric acid, but it's got some really nice properties. One of them is the viscosity. So if you're a toll etch person or maybe a selective etch person where you like to place the gel in a certain area and have it stay there, you want to have an etchant that is viscous enough to do that. And the Max Etch is just that. It stays right where you squirt it and won't slump down into the dentin areas. Like in this case, where we've got the etchant on the enamel, you want to keep it off the dentin at this point. You can see that gel stays right there. Other etchants too sometimes are too, I don't know, chunky, I guess, when you express it from the syringe. So they're too viscous. And again, Max Etch has just that nice gel. It extrudes easily. It stays where you put it. The other nice thing about it is it etches to about 2 microns deep. And we'll talk about this. You don't want to over-etch the dental tubules. So we know when we put the phosphoric acid on the dentin and we rinse it off, we've opened up those tubules. And on the enamel, once we rinse it off, we have the enamel prisms there to receive the resin for micromechanical retention. So we've prepped the tooth out. We have a smear layer on top of our dental tubules. We apply the acid, we rinse the acid off, and we've opened up those dental tubules. What we want the adhesive to do is to be able to seal back down to the depth at which we etch the tubules. And again, with the Max Etch, where we need to have our adhesive get down there about 2 microns, which is doable. So when we rinse the etchant off, what do we do at that point? We want to leave moisture behind. So here's the beach. We don't want it wet like the ocean because that's just going to dilute our adhesive. We don't want it too dry because then our adhesive won't be able to soak in. We want to have it just moist. So if we, when we rinse off our etchant, we can blot off the extra moisture and just see a glistening surface. That would be ideal. If you're not sure if it's too wet or too dry, you can actually use some of these desensitizers like G5, Gluma, Microprime to actually re-wet the tooth surface again. So G5 is an all-purpose desensitizer that seals up the dental tubules and actually enhances the collagen cross-linking. It's antibacterial and actually helps inhibit the MMPs, and we'll talk about that a little bit more. What we see on the photo on the right-hand side really is when you apply the G5 seals up the dentinal tubules by coagulating with the plasma proteins within those tubules. So if you take the G5 and you scrub that over the dentin areas for 30 seconds, G5 with the heme and the glutaraldehyde begin to seal those tubules up. So we've etched it and we've rinsed it off. We put our G5 as a desensitizer, and now we're going to place our adhesive, our bonding agent, over the tooth structure. MPA Max is a great adhesive to use. It's got 0.2% chlorhexidine, which we'll talk about in just a second. It's got ethanol carrier. It is filled 7.5% with a nano filler. If you are using it with a dual cure material, you don't need an activator with it, and you can apply it within a single coat. So it's very easy to use. So let's go back to this. If we've got dentinal tubules with most etchants, on the left-hand side, you'll see that, let's say the etchant demineralizes the dentinal tubules down to 10 microns. Well, the max etch we talked about will do that to 2 microns. So if you're using another etchant, some things you want to make sure you do is you don't want to over-etch the dentin. So you want to place the etchant, the phosphoric acid etchant, on the dentin for about 10 to 15 seconds. Then you want to be able to rinse that off. Again, leave the dentin moist, and then we're going to start to apply our adhesive. Now, when we apply our adhesive, which is this gold color at the very top here, we want to give it time to soak down in between the collagen fibrils to create a hybrid layer. So what you actually want to do is you actually want to scrub it into that dentinal surface. Again, doing live patient treatment programs, sometimes I'll see a clinician just take the adhesive, place it over the tooth, not scrub it, not give it much time at all, but just place it on the tooth, air dry it to thin it out, and then light cure it. We'll talk about that. What I want you to do is give the adhesive time enough to work its way down into those dentinal tubules. Scrub it down into the tubules. Because if we leave a void, if we've demineralized through our etching the dentinal tubules down to 10 microns, and let's say we get our adhesive down to 4 microns, or we've got a 6 micron void, and it's that void, any changes in that hydraulic pressure within those tubules will tweak those odontoblasts, and we're going to get sensitivity. But I mentioned earlier the MMPs, and I told you we'd come back to that. So the MMPs are enzymes that are associated with the collagen, and they have been associated with breaking down our hybrid layer, which is a collagen adhesive interface. And so what we want to do is we want to control the MMPs. Things like chlorhexidine or glutaraldehyde. So that remember, the chlorhexidine was in our adhesive and the glutaraldehyde was in our G5. Research has shown that those will help to inhibit the enzymatic breakdown of the collagen fibers and inhibit the action of the MMPs. And so having that in the ingredients of the products that we used up to this point is helpful. So here's just showing putting the adhesive on, do a big puddle coat there, and agitate it down for 10 seconds. What we want is we want that ethanol to chase the moisture in the dentinal tubules down, and while it's chasing down the tubules, carry with it the resin. So we want to work the resin down into those tubules. On the right-hand side, you see an SEM where they remove the tooth around the resin tags. And so when you go back to work, I want you to imagine working your adhesive down into the tubules to get those tags. The MPA Max has consistent bond values, so you can use it for enamel and dentin with really great 48 and 51 megapascal bond strengths. You'll see that you can use it for zirconia and lithium disilicate. So to enamel, it has a 48 megapascal bond strength, to zirconia 59, and lithium disilicate 69. All right, so we got our adhesive on. We've worked it down into tubules. Now what we have to do is we have to use the air to thin it out, and also use the air to evaporate off the ethanol. So what we're going to do is we're going to hit it with air, and we're going to thin it, and we're going to do this for 5 to 10 seconds. Again, I've seen clinicians during live patient treatment programs where I'm working side by side with them, and they'll just hit it with a quick blast of air. Problem with that is the quick blast of air doesn't really thin it out very well, but it doesn't evaporate off the ethyl alcohol. So that alcohol creates voids in our adhesive layer, because when we then go back in here to light cure that, our resin will light cure, but the alcohol in between the resin particles will not. So it creates a weaker bond. So let's talk about that. When we go in there to cure that adhesive layer, how well are we curing it? We want to make sure we check our lights. So if you have a light that you can check the power output, I recommend you do that. On the right-hand side, you see a tip with a lot of composite caked onto to the end, and that could inhibit the proper amount of light to exit through that tip. The other thing that you want to do is you want to make sure that you hold the light close to the preparation, and to keep it as intense as you can. So in my practice, if I'm placing a crown, if I'm doing a direct composite, a lot of times I'm placing the composite, my assistant will bring the light over. Sometimes she can't see around my hands, and I've kind of got a bear hug on that prep. So I have to direct her or move the light closer to the prep. So if you're doing things the same way, make sure that your assistant can get that light right over the prep. The closer he or she can get that light, the better. That way we keep the light intensity up. So you want to bring it right up to the tube. Now there are some lights, I just want to mention, that put out so much light that sometimes, or so much light and heat that can actually damage the tooth. So if you've got a light like that, you might want to hold it just off the tooth, not actually make contact with the tooth. But one of the things that I've learned recently is shadowing. Shadowing is bringing that light in. Remember, we have a light cured adhesive that we applied to the tooth, so we need the light to hit all the walls of our preparation. So in this case, what I'm doing is I've got a plastic tooth, and I'm bringing my curing light basically straight down over the top of that tooth, and you can see that most of the walls are well lit up. Now remember, I told you my assistant's using with the light, and when she places that over the tooth, coming at her angle, maybe not being able to see how well she's lined up, she could be off just 10, 15 degrees. So in this case, what I've done is I've taken that same light curing unit and I've just turned it a little bit, and look at all the shadows that it creates. Now remember, if I've got a light cured adhesive and I don't get light to it, it's not going to set. So that can be an area of concern. So here you can just see kind of graphically how where the light does not hit the walls, our adhesive is not being cured. This study showed that a 10-degree off angle will result in a 40% reduction in curing intensity. And remember, it's that intensity that actually cures it. And if the light doesn't hit a wall, it has zero curing there. And then we have to worry about that, especially if it's a deep part of the box along maybe an axial wall, and we don't cure that with our light, and we start packing our composite way down there, maybe it will not set well at all. There's different curing lights. I use the Velo. The Velo I like because it has a slim design, and if you look at the light guide, it comes out at about a 90-degree angle to the handle. Some others are not so low profile, so you either have to have the patient open wider, and if you had a patient that can't open that wide, then you compromise by angling that light, and then we have to worry about the intensity. So remember, getting energy to the resin with good access gives us a better, more sure cure. So now we've got everything kind of set up. We've got our tooth etched. We got, well, let's go back even further. We did our prep, we got all the decay out, we've etched, desensitized, we put our adhesive layer down, and now we're getting ready to put our composite in, which is the topic of today. So in the days when I was in school 30 years ago, we learned to use a Tafelmeier matrix to place the restoration, which back then was amalgam. The Tafelmeier worked great. You know, we were able to pack that amalgam down in there into the preparation and push that band right up against the adjacent tooth. But today's materials, like our composites, the Tafelmeier doesn't really cut it. I know there's a lot of clinicians, when I go out and present to different groups, I'll ask the clinicians how many are still using Tafelmeier, and there's still a lot of Tafelmeier use going on when placing composites. So one of the things that I then ask the clinicians is, do you have any issues with your contacts? And many of them do. They don't really understand why they're having problems. So these segmental matrix systems that are available today, I think, are key. I've been using them for the last couple of decades. I can't imagine doing a direct composite restoration with anything else. With the Tafelmeier just creates kind of a straight angle, because the composite's not going to be able to push that Tafelmeier against the adjacent tooth as alloy or an amalgam material that we can actually push down into that box. So with a segmental matrix, the segmental matrix is kind of pre-curved. It gives you the proper contours. It gives you a longer contact interproximally than a Toffenmeyer will. So using a Toffenmeyer with amalgam, yeah, we get some really nice contours. We get nice contact. But when we start using a Toffenmeyer with composite, our contours aren't so good. And this is that band cross-section that I often see. If I see that, I just think, oh, the doctor had to use a Toffenmeyer, and that's the best contact they could get. And we really don't want that. There's not a lot of anatomic form to that. The contact's even slightly open. The patient starts to tell you that they're getting a lot of food trapped in between the teeth, and it's just not a good thing. So the segmental matrices that are available today in all the different rings, these are just some that I went up into the shelves at our office, and we've got a bunch of different ones. We have the V3, Paladin, Garrison, Mega V, and the Dual Force. I'd recommend that you use a segmental matrix, and the Dual Force is a great one. So if I go back, it's the ones on the bottom, the green and the orange. It has dual nickel titanium wires, so you get a nice, strong, stable force that will open the contact up slightly between the teeth. Being nickel titanium, you don't get fatiguing of the metal. These are unique because there's 4 independent interproximal separating prongs that from the buccolingual can get the mesial and distal tooth structure, and hold on to them very firmly. When you put these on, use a little forceps like a rubber dam, and you want something that you can expand and then be able to get back into different areas of the mouth very easily. And with the Dual Force, you can do that. And they are autoclavable, and they resist composite and adhesive sticking to the rings, which is nice. It's never nice to use a ring that your patient sees and it's all kind of gunked up with a bunch of composite. So having a surface that's easy to keep clean works out very well. Now, when you use a Dual Force matrix, there's 3 different matrix sizes. There's a 4.5, 5.5, and the 6.5. In order to place this interproximally, there's some punch pliers that come with the kit. And with the punch pliers, there's a little bit of an X. So if you look over at the photo on the right-hand side, where the pliers have this little crossing from the back part to the front part, just remember that if you squeeze the pliers in front of that X, that will close the pliers, and that helps you to hold the matrices. If you squeeze the pliers behind that X, it actually opens the pliers up so that you can release the matrix. A lot of doctors don't read the instructions, so you squeeze behind that X and you get frustrated because the matrix keeps falling out. Just remember, squeeze the front part. Now, what these do is these actually punch through the metal of the matrix, which works out very nice because you can punch it wherever it's most convenient for you to grab onto it and then place it. And when you're removing it, you can punch it anywhere and just pull it right out. So what you'll see on the left-hand side is there's a little punch that I put right up to the matrix. I squeeze that, and I've actually punched the matrix, and that's what you see on the right-hand photo. So when you put this in, what we're using is the smaller matrix on the left-hand side and the biggest matrix on the right-hand side. So with these matrix systems, a lot of times what my assistants will do is they'll give me the tallest matrix that the system has, thinking that, well, it's going to fit every case that we do. What you see here is on the right-hand side is I put the biggest matrix over there, and I put a wedge in there just to hold it in there while I took the photo. But you can see, I'm going to just turn the cursor on, you can see that from the top of the marginal ridge of the tooth up to the top of the band, there's 2 or 3 millimeters right there. And nature will have it as you fill that up. A lot of times you will fill that up to the top of the matrix, which means you will have much more to grind off. So I always tell my assistant, don't give me the tallest, give me the proper size one. So what you see on the left-hand side is that matrix, it fills in the contact, and where the top part of that matrix curves, let me just hit the cursor again, right in this area, that will create the contours of your marginal ridge. That area right there that matrix creates kind of mirrors the tooth distal to it. So what you want to do is you want to have the proper size matrix that gets all the way down the gingival floor, that goes up to the contact, but then curves and creates that marginal ridge that you want. And that will make your life so much easier. So that's that incorrect fit. You can see we're way above the marginal ridge. And I see doctors do that all the time during the live patient treatment programs. They put the biggest matrix back there, they fill it up, they're 2 millimeters above the marginal ridge of the molar in this case, and they just have to grind it all down. I try to avoid having to grind my restorations down. So at the correct fit, what you're going to see is you're going to see that top occlusal portion of that matrix create the marginal ridge shape that you desire. Now when you fill this prep up and you come right up to the top of that matrix, you're going to have very little that you have to then adjust. So we got the matrix in there. Now how do we have it hold and stay, and how do we seal up the gingival floor? Well, that happens with the dual force active wedges, and they come in 5 different sizes. And these wedges are very unique in that they'll slide in between. So over here on this left-hand photo, I've got the wedge over the interproximal contact of the 2 molars, just so you can see its shape. So it's going to kind of snug in where you see this, let me just hit the cursor again, where you see this large cutout here. Because of the width of the wedge in that area, that will help you slide it through. And then once you slide it through, it can then re-expand, so it's going to contour the segmental matrix against the teeth to minimize flash. And this area right here will be right under your contact, and they'll snug up right in this area so it won't slip back out. Again, you use those pliers to place that. You can grab onto these wedges with the pliers. Works out great. So when you put this, you saw that these wedges have a little bit of a curve to them. So in this case, you can either place the wedge and then the ring. In this photo, I have the ring placed, and we're just going to slide the wedge up underneath there. But because it's kind of like a suture needle, you can kind of come in a little bit of an angle as you slide it in between the teeth. Just kind of view it in, kind of like hooking it in when you suture up a flap. There's 2 different sizes. There's the green ring for molars. There's a orange ring for the premolars. You know, I think every tooth has its own contour. I most of the time will use the green molar rings. But if you've got one, a tooth maybe where that interproximal contact is too small for the green, then you've got the orange as an option. Once we get the matrix in place, got the wedge in to hold it, put the ring down over the top of that. The pliers have a little ball at the end of them. And what I like to do with that ball is to burnish that matrix band against the adjacent tooth. So in this case, the distal of the molar that we're preparing to fill, I'll take that ball burnisher and just burnish that matrix up against the mesial of the distal molar. So we have a really nice contact. So at this point, when we have our matrix in place and the wedge and we have the ring in there, what I want to do is I want to make sure that I have the proper height matrix that hits the marginal ridge of the molar that's going to be restored. When I look down the long axis of that prep, I want to see that the gingival floor is sealed by the wedge that we placed down there. The axial cable margins are sealed up by the matrix in the ring, that ring's holding that matrix right up against the margins to minimize any polishing that we'll have to do once we've cured this restoration. And we burnish that contact up against the adjacent tooth. So if you have those 4 things going for you, it's going to make the rest of the restoration very easy. So clinicians have asked me, well, you know, if I've got a DO or an MO, I can see how I do that. Place the matrix, I place the ring, and we're set. But what happens if I have an MOD, or let's say I have a DO on one tooth and maybe a DO on the bicuspid and a DO on the molar? Well, you can place multi-matrices, and many times this is what I do. I don't like to place one matrix and fill one restoration, then have to take everything apart and then do the next tooth next to it. If I'm going to restore them all, I just put multiple matrices back there. So with this ring, it has a 20-degree offset here, so we can actually stack them. So you can see we have one ring placed, then the next ring mesial to that actually fits right over the first ring. So you can actually stack them one over the other. This is what we call butterfly. So we have one ring going distally and one ring going towards the mesial. And again, clinicians will ask me, well, if I've got a situation like this where the molar has an MOD prep and maybe the premolar has a DO, can I do this all at the same time? I do. I don't end up with open contacts. Again, as long as the matrix on the distal of that premolar, the bicuspid, and the matrix on the meso of this molar right in this area, if I push the matrices together in this area, I won't end up with an open contact, and we do that all the time. So let me just show you again. Go back a slide. This is what we call stacking, because we have one ring over the other. And then this one is what we call the butterfly. It reminds you of a butterfly with the wings going out towards the side. So you can do it either way. This is kind of a combination where we've got stacked on the distal and we've got kind of a butterfly thing going on the premolar area. So you can get really creative. And yeah, I've done this. I've had 3, I've had 4 rings in the patient's mouth all at the same time. As many as the patient can handle, just because it makes my job much easier. I don't have to do one at a time. I can hit all the restorations, do all the etching at the same time, do all the adhesive placement at the same time, desensitization, adhesive, and the filling. And it works out really, really well. Now, I've had some clinicians say, well, you know, I've done all that, and sometimes I still end up with an open contact. And, you know, clinically, we all do things a little bit differently. So not judging a clinician's technique, but trying to find solutions. With the Valo light system, they have these little Proxecure ball lenses, and they just attach the regular Valo light magnetically. So you just pop it on. And what you can do is you can press that. You can actually put that into the box as you're curing the first portion of the composite down there. And as you cure the composite, you're pushing that matrix band up against the adjacent tooth. And that way basically assures you of a tight contact every time. The Proxecure balls are one solution, but as I told you before, if you get everything situated and you burnish that matrix up against the adjacent tooth, you shouldn't need to use the Proxecure balls, but it's just another option. Some clinicians will say, well, I use a rubber dam. Can I get those rings on when I use a rubber dam? And you can. So in this case, you're just showing the rubber dam clamp is going distally, and we are just placing the dual force matrix towards the mesial. So you can do that. They'll fit one over the other. I've also done it where you could have this ring going distally, so the dual force ring going distally over the rubber dam clamp, and it usually fits well too. One other thing, I had a clinician ask me, they tried all that and they're still having some issues. And I told them if there's a small area that won't compromise the rubber dam clamp, you can actually adjust the rubber dam clamp. Like in this one, we're using a ringless clamp, but some rings have a larger body because there are wings to it. What you might do is actually just polish the wings off, and that'll help you get the dual force ring over the area that you're working. All right, now composite placement. Now, if you're going to place a composite, you might as well use a great composite. And Even-S is a composite available from Clinician's Choice, and it's a great nano-enhanced universal restorative composite material. It's 82% filled by weight, 74% filled by volume. It has surface roughness similar to a microfill with wear, much like enamel. So it has a lot of the great physical properties that we're looking for. As far as shades go, it comes in all the shades that I would use, everything from a B1, BL1, BL3, all the way to an A4 in the universal shades. The enamel shades, which are a little bit more translucent, A1 to like a C2 or A3.5. And the dentin shades, which are going to be more opacious, we go from an A1, which you see on the chart, up to a C4 over there. So the dentin is going to be a little bit more opaque. They have an enamel clear, which has 50% opacity. The enamel and the universal are probably the ones that I would use the most. Just a really nice composite, handles well. It has a fluorescence. You know, I worked in Las Vegas for a long time, and you're always concerned with whatever restorative material that you're using, that when the patient went to an area where there were black lights, you hope that it looked like they had teeth when they smiled. And with something like Even-S, it does have that fluorescence, which is important. Now, one of the things that drives me crazy is usually I will use the little unidose compules of composite. And when my assistant hands me the unidose, with the gun, and I grab the gun from her hand, and the compule falls out onto the floor. Well, now we can't use that. It drives me crazy. So then she's got to find another compule. The Composite is a really nice composite delivery gun. The way it locks the compule in, I don't see any way that's going to fall out, and you can unload it very easily. You just grab the tip and push it down, and it pops right out. So I just want to suggest that if you've got some other guns, maybe those plastic guns where you put the compule in and you have to make sure you hold it and you're squeezing it so it's engaged, otherwise they'll fall out, look at the Composite. So now we're all set and ready to go, and it fits in your hand really, really well. When you place your composites, there's, some of us will just use whatever instruments in our tray, and our composite sticks to the instrument, and we don't even get the contours that we really want, and we think, I'm not worried about that because those will grind in our contours. I'll tell you, you can save yourself a lot of time if you've got good instruments. And Dr. Jordan has a great set of composite instruments to get the proper contours that you're looking for. If you haven't used them, take a look at them. It comes in kind of a flat spatula to little points so you can create the occlusal anatomy, create the flat surfaces that you need. And it, again, will save you a lot of finishing time. When it comes to finishing, there's these all-surface access polishers, ASAP. The nice thing about these polishers are, one, they polish very well, but you can use them on a lot of different materials, from composite, glass ionomer, acrylics, porcelain, zirconia, lithium disilicate like EMAX. So you can use it with a lot of different materials and get that polish. So if you're like me, you have a drawer full of different polishers because each polisher was unique for a different material. Well, now we can all use one polisher, and it works very, very well. I took a little bit of the composite, just laid it out into a tooth form, and took the ASAP. It just comes in the little purple and the orange. Just ran each one over the surface of this composite, and it's hard to see, but it just delivered a great shine. So we just went purple and orange, took me like 10 seconds, and we ended up with a really nice shine. So accessibility is great. Universally, the way it polishes is great. And I'd highly recommend some of those products if you haven't taken a look at them before. All right, so we've covered a lot of stuff up to this point. We've gone through the decay out, we've gone through etching, we've gone through desensitizing, we've gone through the adhesive layer, we've gone through different composites, we've gone through how to get the right contour of the composites with our matrices. And now we're going to actually get into the critical use of these materials, because if we've done everything right up to this point, we are set up for success. We've taken care of every little thing that needs to be handled, and we're ready to go. So class 2 composites, again, those with interproximal contacts make up about half of the directs that are done on an annual basis. So let's cover that because they're important. So it looks like this second bicuspid is in need of a filling. So we've got a lot of good tooth structure there. So we're not looking, at least I'm not looking to go with an indirect restoration. Why don't we go with something that's going to be a direct placement? It's going to be easier for me, easier for the patient. So let's go through the sequence that we already discussed. We talked about finding the decay. So here we're just placing some of the green caries finder in there and rinsing it off. If I see any large areas of green left behind, I'll go in there with a burr or hand instrument and remove that. If I see some faint areas, I'm not so worried about that. That's not infected dentin, that is more just affected dentin. So here we got a dual force on, and I'm working with the premolar, and I'm gonna have both the green and the orange dual force clamps on there, just to show you that you can make them fit. I've got one matrix on the mesial, one matrix on the distal. So I'm both wedged up. So if you look down that prep, we've got the gingival floor sealed up. The axial walls we got sealed up because of the dual force rings applying pressure to the matrices. Now we're using our max edge. So that max edge, we're placing it first on the enamel, and then I'll hit the dentin, because one thing I don't want to do is I do not want to over-etch the dental tubules. So we etch that for 10, 15 seconds and rinse that off. You can apply your G5 desensitizer if you want at this point, then you apply your adhesive. Now this slide, again, I want to emphasize that when we put the adhesive on, we just don't wipe it on and then hit it with air real quickly. What we're going to do is we're going to scrub it in. So we're going to take 10 seconds, 15 seconds, 20 seconds, just scrub it in. We're trying to work it down into those tubules. At that point, what I'm going to do, I'm going to hit it with a little bit of air. Why are we hitting it with the air? We're trying to thin it out, but we're trying to evaporate off the ethanol carriers. We're trying to get rid of that ethanol. That ethanol helped us to get the resin down into dentinal tubules, but it's never going to light cure, and it's going to create a void in our hybrid layer, so we don't want it to be there. At this point, what we're doing is we've thinned that out. We got the ethanol evaporated. Now we're going to cure that. We're plasticizing the dentinal tubules. We're sealing it all up. If we get to this point successfully, our chance of sensitivity should be very minimal. So we've got that. Now I put a little bit of the evenness flowable down in the box. And then what I do is I like to place a little bit of sculptable over the top of that and just kind of squeeze the flowable into my axial wall line angle. So I put a little bit of that in there, and again, make sure that I've adapted it well to that matrix and interproximal contact area so it's nice and tight, and I'll cure that. Then of course what we do is we put a little bit more of the sculptable in there, maybe fill up the rest of the box, cure that, fill up the buccal portion of that prep, cure that, fill up the lingual portion, cure that, fill up the occlusal portion, cure that. But what we do is we cure it a little bit at a time. Let's see, I'm just gonna go back, and then I'm gonna go back because I see some of the questions coming through. So then I layer it all in, and I then remove the ring. And what I like to do is remove the ring and the matrices and hit the interproximal area at the interproximal carver just to get rid of any overhangs that may be there. But again, if we have that wedge nice and tight, we should not have any major overhangs. So then I like to cure from the buccal lingual just to make sure we're getting light all the way in. And check our occlusion. Go in there, have the patient bite down, make sure we have occlusal stops. And in this case, you can see on the lingual cusp, we have our occlusal stop. We have our restoration is looking pretty clean there. So we're going to polish that with ASAP, the purple, and then the orange. All right, so that's a restoration placed directly with the evenness and the dual force matrices. So we have a nice tight contour, nice tight contact with nice contours, and I think an aesthetic restoration that I think always looks better a week later once everything's had a chance to blend in. Let me just run down because just see what there's some questions down here. So I just want to see. What kind of burr do you use when doing prepping for the cavity? You know, a lot of times when I'm prepping for a cavity, I'm using a 330 carbide, and then I might go back in there with a diamond. Can we use a bind agent between the layers of composite if we evaporate out the solvent? Yeah, that's a great question. So a lot of people have said, you know, when we're contouring our composite, just to go ahead and wet your instrument with your adhesive. One of the problems with that is, remember, adhesive has the alcohol in it. So yes, if you use your adhesive to sculpt your composite, you can do that. The person asking the question said if we evaporate the solvent, that's the best way to do it. So if you're going to use your adhesive, use that to contour your composite so it doesn't stick to your instrument. Then go ahead and hit it with the air to evaporate the solvent and then cure it. And then another option is there's other unfilled resins that are available that do not have a solvent in them. So that kind of gets rid of that. Slide with the 8 variables. Saw that. Do I bevel the axial walls? You know, with the axial walls, I don't always bevel it. I want to make sure I don't have unsupported enamel on the axial cable finish lines, but a lot of times, especially on the occlusal, you saw I just had a butt margin. Let's see, would you still need a Tofflemire to fill a DO on the most distal tooth? Yes, you're right. If I had a patient that was missing a 3rd molar and we had a DO on a 2nd molar, then I could use a Tofflemire back there. I'm not really concerned about a contact back there, so a Tofflemire would work well. What do we use to remove the overhang? That's just, I use the interproximal carver. You know, it's back from our amalgam days when we pack our amalgam and use that to get in between the teeth to get rid of the amalgam overhangs. Let's see. What's the thought? I'm just going to answer some of these questions, then we'll get going again. Thoughts about slap preps. Slot preps and retention with them. I think if you can do a good slot prep, it works out really, really well. I think it's fine to do. All right, I'm gonna pick up. So we're gonna hit the value of aesthetic smiles. So I know the listeners are from all different parts of the globe. In the United States, this was a study that our ADA put out, said studies from earlier research shows that people that have attractive smiles are perceived, now it doesn't mean that they really are, but they're perceived to be more intelligent, socially competent, have more positive personality, better social interactions, and more favorable professional ratings. So, it's probably one of the drawbacks. If you look better, you're perceived as being a better person, so to speak. So what are some of the things that we can offer our patients? Here's a patient that had a diastema, a space between the two centrals, the maxillary centrals. One of the things we could consider is ortho to close that up. In this case, what we want to do is just bond. And one of the things that made this difficult to bond, some of you might say, well, it's a really small space. But one of the things that makes this difficult, it's a really small space. So what we're going to use is we're going to use the Even-S composite because I like the way it polishes up, but we're going to warm it up to give a little bit better flow properties, especially when I'm trying to get in this really small space with some BioClear matrices. So here I'm going to put a rubber dam on, and what the rubber dam is going to do is it's going to give me good isolation, but it's going to hold the papilla down, and that's so that we can avoid any black triangles in that area. So this is actually Caries Finder, just to be sure that we get all the plaque off, because this is going to be a very conservative prep. It's really a no prep situation. So we go with the Caries Finder. I use a micro-etch all the time for these restorations. Micro-etch doesn't really remove the enamel, but it creates a roughness from micromechanical retention. It gives me a much better chameleon effect, and it just cleans that area. So you can see all of our caries detector is gone. We get our little BioClear matrices in there. I'm doing both the mesials of both centrals at the same time. We get our max etch in there because it flows up in that area very well to wet that enamel. We rinse it off. And now we apply our adhesive. So we get that adhesive up in there, our max MPA, we get it up there, we thin it out, we evaporate off the ethanol, and then we light cure that. So now we put just a little bit of flowable in that area, and then we take our warm Even-S and we place that right into that area, push it down into the area, kind of sculpt the best we can. It's kind of a limited amount of sculpting that you can do, but the nice thing about these matrices is they're creating the contour up in the papilla area. So now we've got it cured. We pull those matrices out, do a little bit of polishing. Again, these were no prep. Removing a little bit of flash that might be up there in the papilla area. Now contouring the gingival areas, just polishing it up with a little silicone polisher. And we ended up with, I think, a very nice end result. You can see the polish. It's hard to tell if you didn't know that it wasn't natural tooth. It'd be hard to discern, but we've sealed up that diastema, and there's no black triangle up in the papilla area. And remember how small that space was, and that's basically what made it so difficult. We are going to use our composite in other situations. We're going to use the U-veneer coming up in this next one. U-veneer is just a former that's clear, and we're able to squish the composite up against the tooth so we don't have any voids. And when we remove that form, we'll have a very smooth surface. So I had this patient that came in. She had some porcelain restorations from the right central off her left-hand side. She wanted her right lateral and her right cuspid to match the colors of those teeth a little bit better. We gave her the porcelain option, but because of cost, that wasn't something that was viable at this time. So we went in there. We're using our U-veneers. We place some mylar in between the mesial, the lateral, and the distal, the cuspid. I'm micro-etching this so that we get a better etch. So we place that. Now let me get rid of this. There we go. So we place the etchant, we rinse the etchant off, and you see we have a nice frosty pattern. So we place our adhesive, we use the air to thin that out, and I'm flossing just to remove the adhesive interproximally. And here comes U-veneer. So I take a universal composite like Even-S. I like to warm it up. You don't need to, but I like to warm it to make it flow a bit easier. I squish it down over the facial, that lateral. with the form in place, we wipe off the excess up at the margin areas, and we light cure through that clear form. So here we remove it. You can see we have a nice shine, but we have a flash around the margins in this area right there. And we'll go back and we'll clean that area up. We go back and do the same thing on that right cuspid. And we smash the composite down. We light cure through the form, peel that off. We go back in there, and this is immediately post-op, so you see a little bit of redness to the gums. But in this area, you can see we just have removed a lot of the flash. But the important thing is just seeing the nice shine and contour that's attained. So in the upper right-hand photo, you can see we've got composite on the right lateral and cuspid, and it's matching the porcelain very, very well. This is, I saw one of the questions. I know you guys are doing a great job. You have a lot of questions come in. Yeah, there was no cord used for that or the diastema closure. This was a patient that came in who wanted a very conservative smile makeover and a lot of wear and tear on his teeth. So when he first came in, I said, well, one of the things that we could do is we could do direct composite veneers. And I was thinking about the U veneer at the time. So we took some composite on his right central. We just cured this composite onto his unprepared tooth with the U veneer. And so you can see I haven't bonded this on. It's just basically so we can smooth it up, give him a mirror, and let him take a look at it so he can see what it looks like. So he decided he liked the way that looked, and we came back in and did his, let's see, first bicuspid to first bicuspid with the U veneer method. So it was very fast, easy, and he was a happy patient. This is one where this was a roundhouse bridge that went from molar to molar, right to left-hand side, and somehow the patient fractured the porcelain off on 8-9. So what do? We pull out the U veneer and a great composite like the Even S. So we're porcelain etching the porcelain that we have left behind, silanating. Silane's a coupling agent between the porcelain and our composite that we're going to place over the top. Pays a little bit of white opaque to block out where the metal is showing through. And we're just using the U veneer with our composite, showing how what you see on the right-hand side is basically with very little polishing at all. The U veneer and a good composite like Even S just creates a very nice contours. And the patient, again, was happy. We didn't have to replace the bridge. That would have been a really big job, but we were able to repair the porcelain. So we covered a lot of things. Let me just go down to the questions again, and let me answer as many as that I can get to. Let's see. One of the things, going back to the dual force, is how to keep the wedges fully seated. You know, I think it just comes down to having the wedge that's the right size. If it's too small, it will pull out. If it's too big, it's too hard to get in between. So I'll tell you, most of the time I use the smallest wedge or the next one up. But I think it's just more of making sure that the wedge gets underneath the contact. If you slide the wedge in and it's above your gingival floor, it won't stay down. So just try to keep it low enough. How do you avoid getting voids at the bottom of the box in a DMO prep? Do you line it with flowable? Correct. So what I do in my box is I'll put a little bit of flowable down there, a little bit of stackable over the top, and then kind of pack the flowable down into the deeper portion of the box, and that pushes my flowable out, so we have no marginal gaps at all. Mention one of the questions: do we use wedges for the centrals? No wedges. Without the rubber dam, would I wedge the BioClear matrices that we use to close the diastema? I will tell you, I would just place a rubber dam. One of the problems if you just use a wedge is the wedge could cut the tissue, and then you have to deal with bleeding. So I would use a rubber dam. There's less chance of having to worry about that. Yeah, I know somebody was joking about having those diastemas. You know, are they sexy with the Lauren Hutton or Arnold Schwarzenegger look? Yeah, some patients like them, so I agree with that. The U veneer matrices, do they go through the interproximal? They don't necessarily go through the interproximal, so I try not to open up the interproximal contact if I have to prep the tooth at all. How long do you say the U veneers last compared to laminate? I assume porcelain. And how much less is it? Well, it depends. The prices are hard to say. They should be less because there's not a lab fee involved, which can bring the cost down dramatically. How long will they last? I tell patients, it just depends. They could stay over time because it's a resin, it's not porcelain. But again, using a nano-hybrid composite like Even S, we should have minimal staining. A lot of great questions coming in, but I think our time's almost up. Let me hit this one. When we're preparing the porcelain, after the silane, do we place it? He said yes. I kind of skipped some steps in there. I apologize for that. So when we prepare the porcelain, we do the porcelain etching. We rinse out the porcelain etchant, then I apply silane over the ceramic because silane is a coupling agent between the ceramic and the composite that we're going to place over the top of it. I silane the surface, usually for 60 seconds, dry that, then place the adhesive. You're not going to have dental tubules to soak that up, so I'm going to thin it out to evaporate off the ethanol, then light cure that, and then place the composite over the top. So I appreciate that. That was a great question. I think we're at the end of our meeting. Let me hit this last slide. I have an email address down here, so if I didn't get to your question, because there are many coming in, I apologize. But you can always email me directly, and I'd be glad to answer the questions that you have. Anyway, thank you very much for attending to this evening's program, and I hope to see you at a future program in the near future. Take care.